Okay, so we'll go on to the first talk, and that is by Dr. Anusha Ajwani from Bhopal, and she is the daughter of the illustrious father, Dr. Ajwani, and she is going to talk on post-classic epithelial ingrowth causes, prevention, and management. Dr. Anusha, please.
Thank you so much, sir. Thank you, AIOS, for giving me the opportunity. I'm Dr. Anusha Ajwani, and today I'll be speaking about post-LASIK epithelial ingrowth, its causes, features, prevention, and manage. I'll try to be quick as far. So, epithelial ingrowth is the presence of corneal epithelium in an area where it does not belong, and after LASIK, it occurs in the interface between the flap and stromal bed of the patient's cornea. The incidence following primary LASIK is very low, estimated between 0% to 3.9%, and it is increased when the flap is lifted for retreatment or enhancement, ranging from 1.7% to 23.3%. The corneal epithelial cells can be introduced into the interface in two ways. Firstly, during the microkeratome pass or other parts of the procedure, and secondly, due to a loss of contact inhibition and the presence of a pathway to the interface. Coming to the risk factors of epithelial ingrowth following LASIK, these can be non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors include patient factors like presence of corneal epithelial basement membrane dystrophy, history of recurrent corneal erosion, type 1 diabetes mellitus, older age group. Hyperopic LASIK is at a higher risk of developing epithelial ingrowth as compared to myopic LASIK. Microkeratome assisted is at a higher risk of developing epithelial ingrowth. Prolonged manipulation of the flap and excessive instrumentation at the interface, partial flaps, flap misalignment or dislocation. Coming to the modifiable, the surgical technique used during retreatment is also responsible, and there is a higher incidence of ingrowth with direct flap lift with forceps as compared to cleaving with spatula before the lifting. Corneal epithelial injury, buttonholes, and spillover ablation at the bed margin. Coming to the classification, so based on the location, clinical features, and severity, it can be classified into 4 grades using the Provost-Machar classification, and this classification serves as a useful aid for consistent and standardized grading and provides guidance on the treatment strategies. According to this classification, the grade 1, in this there is a thin growth, well delineated white line along the advancing edge. There is no flap change. The location is within 2 mm of the flap edge, and usually no treatment is required. In grade 2, there is a thicker growth. No demarcation line is there along the nest, and they may have rolled or gray flap edge with no melt. Usually no urgent treatment is required. However, patient may need it within 2 to 3 weeks. In grade 3, there is pronounced growth. There may be presence of opaque ingrowth, geographic areas of necrotic cells with no demarcation line. Usually urgent treatment is required, and the location is usually more than 2 mm from the flap edge. In grade 4, there is aggressive growth which may result in flap melting, which can threaten or affect the visual axis, and urgent treatment is required. Coming to the prevention, so to avoid epithelial ingrowth, patient selection is very important. Patients with the stated risk factors may achieve better results with PRK than with LASIK, thus avoiding the possibility of epithelial ingrowth. Apart from that, we should avoid prolonged manipulation of the flap, clear any epithelium, tags or debris from the stromal bed prior to flap repositioning, apply BCL when epithelial defects are observed. It is always a good idea to use new blades and with minimal and careful use of topical anesthesia. Coming to the management, so for mild and non-progressive epithelial ingrowth, that is grade 1, no treatment is usually required. Carefully, we need to observe the patients to ensure that the growth is not progressing. Intervention is needed only when epithelial ingrowth appears to be progressing or affects the visual acuity or causes flap melting. So the most common treatment strategy is mechanical debridement of epithelial ingrowth from the flap stromal interface and from the inner side of the flap, followed by careful repositioning of the flap and avoidance of any intraoperative or postoperative epithelial trauma. It is a good idea to resect the epithelium from around the flap bed. Use balanced salt solution to irrigate the interface, the flap, and the stromal bed to ensure removal of all the epithelial cells. Then replace the flap, followed by placing a BCL. Flap suturing, fibrin glue, and ocular hydrogel sealant at the flap edge have been proposed to facilitate secured flap adhesion. In refractory cases, various adjunctive therapies such as ethanol, mitomycin C can be used to help eradicate epithelial ingrowth. Amniotic membrane grafting can be used in cases associated with flap injury or melting. And in severe ingrowth with melting and folds, it is better to remove the flap and allow for self-healing. The use of ND-YOG laser has also been proposed as a novel technique for treating epithelial ingrowth. It produces short individual pulses of focused infrared light, around 30 to 40 pulses of low energy, focused slightly posterior with respect to the epithelial growth and starting in the center. The power is adjusted to the minimal amount to form bubbles. At the margin of each bubble, new spots of laser are shot until the entire area of epithelial ingrowth is treated, thus sufficient for blocking progression and to decrease the size of epithelial ingrowth. So here are certain images. In the first image, we see that the epithelial ingrowth is there at the interface. In the second image, this is after 1 month, after one session of ND-YOG laser treatment, epithelial ingrowth has well-defined borders. In the third image, it is at 1 month after second session of ND-YOG laser, and epithelial ingrowth has further decreased in size and density. And the fourth picture is 2 years after ND-YOG laser and demonstrates minimal scarring in the interface at the site of previous epithelial ingrowth.
I think you have to complete now.
Yes, ma'am. Last slide only. So coming to the conclusion, with the continuing rise of LASIK procedures, it is important for all ophthalmologists to be competent in recognizing and managing the post-LASIK complications. When appropriately managed, good visual prognosis is usually achieved, and the use of chemical adjuncts and interventions may be required in aggressive or refractory cases in order to achieve complete and permanent eradication of the disease. Thank you.
Thank you. Thank you for a good talk.
Thank you, ma'am.
Our next speaker is going to be Dr. Subhash Prasad, who is going to talk on reverse implantation of phakic IOL, how to detect and correct. And just before that, just one question for, I think I'll ask Sujata this question. Sujata, when there's an epithelial ingrowth, when do you decide that you will do a YAG, or when do you decide you will debride, and when do you decide? Watching, of course, very stationary ones. So,
I think any symptomatic epithelial ingrowth has to be dealt with. If it's a very small local nest where there is no connection to the exterior, then you can wait and watch. And if your patient is having recurrent corneal erosions or pain, then probably you can try to YAG it. But YAG is not completely successful in most of these cases. So in which case, if it's a large epithelial ingrowth, definitely lifting would be the best choice.
a YAG laser more creates a scar around it. So in a peripheral epithelial growth which looks that it could progress, maybe you could think of doing a YAG, but I think a final answer is debriding. I think we should all have our laptops connected before the previous presentation gets over, because it's very difficult.
Yes, this is actually in our space. This is not mine. This is our AV team's audio-visual piece. Yeah. Good evening. At the outset, let me welcome you all once again to this first midterm conference. I would be speaking on a topic which is not so uncommon, particularly for the beginner. So it is very important to recognize this problem and handle this. So why the phakic IOL is so popular nowadays? Because of its ability to take care of the high range of refractive error, particularly myopia, and being reversible procedure which offers very high quality of vision, and there is potential gain in visual acuity also. And this correction can be, this procedure can be adopted for those patients where the corneal thickness is not allowing to go for the LASIK procedure, and there are less chances of dry eye. So let us come with the real case scenario. A 21 years high myope lady underwent this phakic IOL implantation for myopia of -8.5 diopter in the right eye, and next day the visual acuity was 624. That was quite unexpected, and there was slightly low vault, but I asked the patient to come after 3 days, but she reported after a week. And when she came, the vision was actually 624 parts, and there was pigments on the phakic IOLs, and there was extremely low vault in center. And when I dilated the eye, I could see that the posterior or the convex part of the actually IPCL was touching the anterior capsule of the lens. And there was some specks of anterior subcapsular opacity also. So this is the street lamp picture of the patients showing pigments. Vault is very quite low, and the anterior segment OCT actually clinched the diagnosis that it was reverse implantations of the phakic IOL. So there was no option but to take out this lens. And whenever we get such cases, we have to immediately take the patient to take out this lens, otherwise it can cause cataract, and this cataract can progress in no time. And removing the lens is again very much actually a delicate procedure. One has to take care of the endothelium of the cornea and the lens as well, and just nudging out the haptic, and then it can simply be pulled out. And after the second procedure, the vault increased to the satisfactory level and patient improved. So what is the reverse implantation? Actually, this is one of the rare intraoperative complications of the phakic IOL implantation due to most of the time due to incorrect loading technique or due to intraoperative flipping or failure to recognize the incorrect side opening into the anterior chamber. So everyone has to follow certain rules and has to be very careful while loading the lenses. There are some marks on the lenses like the prototype ICL lenses. There is a hole in the leading right side, and in the IPCL there is a bump on the left side with 2 holes which actually be placed in the superior part. So the implantation technique should be, for that one has to carefully pay attention on the loading of the ICL and IPCL so that you do not end up in the problem. So while loading, you always look at the leading haptics should be on the right in the ICL, and when in the IPCL, you have to see that the bump is on the left side. And once you do that, there are less chances that there will be incorrect unfolding of the lens, but sometimes it can flip. So at that time also one has to be very much vigilant. So this was a case of IPCL which actually unfolded in a wrong direction, upside down. There was no problem with the loading, nothing, but somehow the lens was opening in the improper direction. It was holding up, folding in the upside down position. So just see here, the bump is on the right side. It should have been in the left. So at this point of time, I thought to remove, but I thought to give chance, I injected the high quality viscoelastic below the lens and above the lens, and tried to roll it like a paper. And I with no surprise, the lens actually could be re-inverted back into the proper direction without damaging the anterior capsule and the endothelium or cornea of the patient. So this can be attempted, but this is risky also. One has to be very much I think that very much expert in doing that, or would say that rather you don't take chance. So this lens was again re-inverted back. So why to recognize inverted phakic IOL? Because of the complications of progression of cataract, secondary angle closure glaucoma, and recurrent iritis. So how to recognize? Once you see that the vault is very low, less than 250 micron, then you must suspect it. Whenever you have a doubt, dilate the pupil and see whether the lens is in the proper way or not. Or anterior segment OCT can clinch the diagnosis. So what to do? There is nothing, no option except to remove this lens and implant with other lens. So just to summarize, reverse phakic IOL implantation is an important and rare intraoperative complication, particularly for those surgeons who are venturing into these phakic IOL implantations. And one should be very much careful while loading and while injecting the lenses so that you don't end up in the problem. And always suspect when you find a low vault post-operatively. And anterior segment OCT can be very useful to clinch or to confirm this diagnosis, and it should always be explanted once you get this. So thank you so much.
Thank you, Dr. Subhash. This is one of the tough challenges that refractive surgeon faces. In ICLs, the most important step is loading and proper delivery. So otherwise it becomes very difficult to handle after that. So because of the paucity of time, we'll move on to the next talk. That's by Dr. Sonu Goyal.
So
Smile. He will be talking on Smile. Smile Pro. Faster is better.
So very good afternoon, and thank you very much. So I'll be just rushing my talk So Visumax Smile Pro, the faster is better. So this is the new baby in our hand. And for people who have not been using, not been doing Smile, just a quick recap. So basically, essentially in Smile, we are creating a lenticule which is extracted through less than 4 millimeter, and we are now doing almost like 2 millimeter incision, as against the standard LASIK surgery where the hinge itself is just 4 millimeter and the rest is the cut. So Smile basically essentially involves 4 basic steps. So you have a lenticule cut, you have a lenticule side cut, you have a flap cut, and then you have a flap side cut. So just watch carefully. This is what we had. This is what not now we have, and just watch the two procedures going in. And believe me, this is just 8 seconds in a zip of a blink, and you have the whole procedure done, as against the 28 seconds or the 30 seconds standard that we were doing with the Visumax 500. So gone are those days where we actually used to have those suction losses, tachycardia, and blowing of adrenaline into our system. So what Visumax 800 has given us is this is the latest generation femtosecond laser, and what has made the change is this 2 megahertz, the laser source. So this basically has transformed into two major things. So easier tissue separation. So there is a reduced laser time, and this also makes the tissue separation much easier with the Smile Pro. So it creates the lenticule in less than 10 seconds, and for a flap it's less than 5 seconds, and this is basically because of the faster laser pulse repetition rate and the scanning speed of almost 2 megahertz as against the 500 hertz the machine was. So shorter suction time, which increases the peace of mind and reduces the stress of the patients during the laser treatment. So this is how the workflow basically involves. So you have this the arm, the laser arm swelling in, and with this the beautiful joystick control. And these are these ultrasound sensors which actually assist in actuating these robotic arms, and then comes in the microscope. And this is a wonderful microscope that the Zeiss has gone with variable controls in it, and the lenticule can be easily extracted. So this is what we've been doing now. So this is the visual from once the patient has been, the paint draped and the speculum applied. So this is the joystick of the bed, which is hardly taken into consideration. So I'm seeing through the microscope, adjusted. Then you press the laser microscope, which swirls down, and this is the joystick here. And once you have switched on the board, the joystick, the moment you start moving in, and this is the laser component which moves down, and you see on the side the cameras here. And once this is there, this is the interface, and this is just, it's a magnetic. The moment you touch, it gets hooked on, and then you have the screen on here. And this is the center align and the torsional line, the cyclo align here. So very carefully, if you see here, the patient is looking out of the green light. You ask, and even in dilated patients, the patients can be well taken. I'm talking here, the XY coordinates from the atlas can be fed in, where the XY components, so directly the angle kappa based treatments can be done. And watch carefully, this is an unedited, just 8 seconds is the total time, just blink, and the procedure is complete. So gone are those days where we actually used to just wait and look at those tables where the suction loss occurred and how to tackle those conditions. And just watch carefully with the recent 1.2 software upgrade. What we now have is 3 micron separation for the lenticule and 1.5 for the side cuts. Just watch carefully as I go in. It's almost a free floating here, so I don't have any it's just a very smooth dissection on either side. Just watch now. I just go left, leave a stump there. I go right here, and it's a very smooth dissection either ways. And the lenticule can easily be hydrodissected, thanks to Gaurav for teaching us. And this is the whole surgery. Just few minutes of a laser application and few minutes of the lenticule extraction, and wonderful workflow. This is the day 1 picture. Hardly any visibility of the side cuts or the laser marks. So the two beautiful aspects of this is the cyclotorsion alignment. So watch carefully. Once I've docked in here, I can on the fly rotate and then align the cylinder. Shortly we'll be aligning it with the IL Master 700 and with the Forum software, which will give us this the cyclotorsion adjustment. And similarly we have this ocular align, and just watch carefully. So as we dock here, the XY from the Atlas has been fed, and automatically it aligns accordingly onto the vertex position. So the various competitions available. I think this is the fastest lenticule separating machine. So the two basic concerns with the Smile were, the two basic concerns with the Smile were the challenges and complication of lenticle extraction. The beautiful paper from Dr. Tatyal explaining it. So, and the second was the suction loss. So the treatment time with Visumax 500 was almost like 28 to 35 seconds. And the various multi-center studies showed the suction loss to be close to 1.34%. So I think gone are those days where you have just less than 8 seconds of a treatment and very smooth dissection of the bed. So to take home message, it's a better refractive results, quite predictable and very easy onto the patient and onto the surgeon. Thank you so much.
Thank you very much, Dr. Sonu. That's truly a way forward in Smile procedures. We shall, paucity of time, we're not going to be discussing. Go on to our next speaker, Dr. Ramurthy, who's going to be talking on phaco after phakic IOL. So, and I don't think we have any.
Thank you. I'll be speaking on this topic of phaco after phakic intraocular lenses. Most often you come across a situation like this where there's an excellent vault, a very clear lens, a well-centered intraocular lens, a very happy patient. But sometimes you come across these situations where there is a anterior subcapsular opacification, and especially if it impinges onto the central visual axis, it starts impairing vision when you need to take care of this. Some of the factors which promote the occurrence of cataract, if it is just a nuclear sclerotic cataract which can occur in highly myopic patients, obviously it's not the phakic intraocular lens which is at fault. But if it is a low vault, especially if it's less than 250 microns, high myopic patients, if more than minus 15 diopters of patients, and if the age is beyond 40 years, and especially absence of the central port, are considered to be the factors which predisposes to the occurrences of anterior subcapsular cataract. Now that all the imported as well as the Indian phakic intraocular lenses come with a central port, that is a significant step forward in preventing the occurrence of these ASC cataract. But just because the vault is low, that's not considered to be an indication for removal of the lens. You can see this pair of eyes of the same patient followed up by us for about 5 years. Here I think the vault is just about 137 microns. The other eye is just about 84 microns. But you can see the lens is absolutely crystal clear. Obviously, just because the vault is low, you don't have to go ahead and expand these lenses, but follow them up closely just for the semblance of occurrence of an ASC cataract, in which case maybe the lens can be taken out. As far as if at all there is a significant cataract, one of the good advantages of getting a cataract after a phakic intraocular lens compared to a corneal refractive surgery is that there is no alteration in the corneal curvature and there is minimal thickness of the phakic intraocular lens. So basically you can go ahead with your conventional ultrasound or the laser platform, and most often you are dealing with extremes of refractive errors. So Barrett Universal as well as the Barrett toric calculator is the one we use, often using our IOL Master 700 other optical biometers, and it works quite well. No variation as far as the axial length or the curvature is necessary. A typical case, I operated on this case in the year 2012. As you can see, extremely high myope, minus 24 with minus 27. Those days with a significant amount of cylinder. Those days it was not the centraflow that was available. 10 years back, minus 23 was the lens which went inside bilaterally. Developed in the year 2020, This was what the immediate post-operative results was. The patient was quite happy in spite of the significant refractive error that was left over, because much of his almost the refractive error had come down by almost 20 diopters. But then he did develop a cataract and presented to us bilateral cataract 10 years later. There's some amount of progression of the myopic error compared to what we saw in the immediate post-operative period. But this is the way you take the lens out. Basically, both the Indian lenses as well as the ICL comes out through a 2.4 or even a 2.8 millimeter incision. All I do is to just bring out one of the haptics. It's a 2.8 millimeter incision that I have created in this particular case. And using a hand-over-hand technique, you can bring the lens out, and it easily slips out because of its the collamer material or the hydrophilic acrylic material, which is extremely pliable. The lens can just come out very smoothly. And you can see the ASC cataract that is impinging onto the center, that's causing a drop in the visual acuity. Most often these patients, that was a patient who had a minus 27 diopter power to begin with. This is just it's always a good idea to stain these capsules, because invariably there is anterior subcapsular fibrosis. And when you run into these areas, it's essentially a capsular excess, forceps, the capsular excess, whatever you are comfortable with. It's important to get an intact capsular excess, because you require a good overlap of the rexis margin over these very soft cataract and these highly myopic eyes. And it's a phaco flip technique that we employ, usually using a high vacuum, but a very low intraocular pressure. Aspiration, it's phaco aspiration that's done. Hardly any phaco power is used. And because of its a minus 7 diopter lens, it's a 3-piece intraocular lens that goes inside. You can see that lens power, and that's the lens being slipped in. And exactly the same thing was done in the other eye too. And you can see the result that you achieved in this case after compared to the phakic intraocular lens. Obviously, intraocular lens takes care of the refractive error even better. But this is not the way to do it primarily because of the retinal complications that can be associated with it. It's also possible to use a laser platform even in the presence of a phakic intraocular lens, especially because there's a significant anterior subcapsular fibrosis. If you can use the laser, then you get an adequate rexis, and you are able to exactly titrate the position of the detents in such a way that they overlap onto the anterior lens surface, creating a rexis. I'm going to skip this. Go forward a little bit. This is what you see is essentially to show that the laser can go through the material of the lens and create an adequate rexis. It's not a free floating rexis that you get, but a nice template of the rexis, and essentially you can go ahead and then do in the conventional manner, create a rexis of about 5.5 millimeters, and then implant usually a highly myopic lens that goes into the bag, and giving you a fairly good outcome. Let me skip that, and this just to finish off. This is a case I started off with iris clip lenses way back in 2004. The first 3-4 years it was essentially iris clip lenses. Some of these patients are now coming back to me with cataract. As you can see here, it's a nuclear sclerotic cataract, though primarily the lens was not responsible for this. Essentially what you do in this is to create a 5 or a 6 millimeter sclerocorneal incision, because that's the PMMA optic size, and then you disenclavate the haptics as you saw in this particular case, and then you just inject a little bit of viscoelastic. Often the endothelial cell count is already compromised in these cases, so your surgery has to be extremely gentle. And then once you have done that, it's a good idea to suture up this incision and then switch over to your temporal clear corneal incision and do it the phacoemulsification the manner that you are accustomed to. Almost all these cases you are seeing a 3-piece lenses, because they are all minus power lenses and essentially being implanted in highly myopic eyes. Thank you so much for your kind attention.
Thank you, Dr. Ramurthy, for an excellent presentation. With this, we'll come to the end of the session. If there are any questions, we can take 1 or 2 questions. We started the session late, but we could finish on time. Though we missed some good talks, we couldn't cover that. So thank you, Dr. Ramurthy. I also thank my other chairpersons.